Welcome to the Vital Spirit podcast. I'm Dr. Kelly Livingston, a naturopathic physician and your guide to a new health reality, one that connects body, mind, and spirit. Together, we'll dive deep into the art and science of holistic healing. Through working with hundreds of women through midlife transitions, I've discovered something profound. Most of our physical and emotional challenges are rooted in a maladaptive stress response. And true healing begins when we regulate our nervous system. Each episode will explore complex health topics in simple, empowering ways, uncover the deeper wisdom within each of us, and share practical tools for nervous system regulation to help you awaken your vital force and create lasting wellness. So, if you're ready to reconnect with yourself, your health, and your purpose, let's begin this journey together so you can experience life more fully human and deeply healed. After I recorded this episode, I realized that it was about an hour long because clearly I felt compelled to share a lot on the topic of SSRIs. So we broke it down into two parts for you. So right now you're going to hear part one, and then tune in next week for part two. Hi, and welcome back to the Vital Spirit podcast. I'm your host, Dr. Kelly Livingston. And today we're diving into a topic that sits right at the intersection of clinical truth, nervous system reality, and the spiritual journey of being fully human. We're talking about SSRIs and the serotonin story we've been told for 4 decades. We're talking about what's really happening in the body when depression shows up, and we're talking about healing, informed consent, the microbiome, nervous system states, hormonal shifts, trauma physiology, and consciousness. I'm also sharing something personal, how depression has moved through my own life and what I've learned from some of my deepest descents. Before we begin, I want to say this clearly. This is not an anti-medication episode. It is a pro-truth, pro-context, and pro-root cause episode. This is an episode about informed consent, and that will make sense as you continue to listen. And if you haven't listened to episode 36, the Dark Night of the Soul episode, I strongly recommend listening to that one first. It maps the emotional and spiritual descent of depression. This episode reveals the physiology underneath that descent and the science behind why so many women are not being given the whole truth. Together, these two episodes are a much bigger conversation about what depression actually is and what healing actually requires. Okay, so a quick foundation. Before we talk all about serotonin and medication, we need to talk about depression itself. Depression is not just sadness, it's not a flaw, and it's not weakness. It is not a character issue. It does not mean you're a bad person or you're not strong enough to make it through the day without severely low moods. Depression is a clinical whole body condition involving changes in mood, motivation, cognition, inflammation, gut function, immune signaling, energy production, circadian rhythm, hormone balance, and definitely the autonomic nervous system. Depression is one of the most common medical conditions in the world. In the US alone, roughly 21 million adults experience at least one major depressive episode each year. And worldwide, depression is now the leading cause of disability, according to the World Health Organization. And these rates are even higher for women, especially in perimenopause, where the risk of depression increases by 2 to 4 times, independent of life circumstances. That's pretty wild. I want to name this because I want you to feel the truth in it. I want you to feel that you are not alone if you struggle with depression. You are not broken. You definitely, as I said, are not weak, and you are in profoundly human company. And I also want to say up front that I will be recording a dedicated full episode on depression, what it is, how I treat it, why midlife is this vulnerable window. And I'll be doing a full episode on bipolar disorder because many women are misdiagnosed or misunderstood when trauma physiology, HPA axis dysregulation, and hormonal transitions are never explored in the context of these diagnoses. But this episode here is because women ask me every single week, are SSRIs safe? Why don't I feel better? Why do I feel numb? Why are these so hard to get off? Why did nobody tell me about withdrawal? If serotonin isn't the cause of depression, why am I on a serotonin drug? What else can I do? So today we're specifically focusing on serotonin, SSRIs, the science behind how they work, the research on what actually causes depression. We'll talk about nutrient depletion, the gut brain axis, of course, trauma physiology, consciousness, emotional blunting that comes with SSRIs, withdrawal, and evidence based alternatives. As always, my goal is to go a little bit deeper. So, the story that women are not told is essentially the reason that I'm here recording this episode today, because this gets me angry. It makes me really sad. And essentially, every single week in my clinic, I hear a very similar painful story from women. I'll have a woman in perimenopause or menopausal age range, so let's say about 35 to 55 in front of me, and maybe they're exhausted, overwhelmed, or burned out. Maybe they're feeling better at this point in life. Maybe they've dealt with things like PMS, anxiety, midlife insomnia, blood sugar crashes, right? Exhaustion, and maybe they've gone to the doctor. And in a 10 to 15 minute visit, they're handed an SSRI. Now, they might also have come into my office having been on an SSRI for 20 plus years. And as I speak with them, I learn that no one was asking them, how is your thyroid? Let's look at whether your thyroid is causing this mood imbalance. What's going on with your estrogen and progesterone? Maybe your low progesterone is creating anxiety, or estrogen fluctuations are triggering inflammatory depression. No one's asking, what is your cortisol rhythm doing? How's the health of your HPA axis? How's your gut health, which you're going to learn in a few minutes is so important. How's your inflammation? Are you in fight or flight or dorsal vagal shutdown? We go into these nervous system states in previous episodes, so you can go back and listen to those. What's your sleep like? Have you experienced trauma? What's happening in your life? What are your stress levels? Instead, in a very quick visit, a woman can be told, you have depression. Essentially, their symptoms match up with the label of depression. It's a chemical imbalance. Here's your pill. Here's your prescription. And this is the story that I lived personally myself as well. In my early 20s, during one of the harder mental health seasons of my life, I was handed a medication after one visit. And this was someone who cared about me deeply. They were a personal referral from my dad. It wasn't malicious. It was the system she was trained in. No one looked at my hormones. No one asked about my gut. No one checked nutrient levels or inflammation or the years of nervous system hypervigilance and trauma physiology I was living inside of. No one asked about trauma as a child, none of that. And this is the story of millions of women. It is definitely the story of hundreds of women that have shown up in my office. And the truth is that the serotonin theory of depression, this idea that we have low serotonin, it was never grounded in good science. It was a metaphor. And it has now officially been debunked. Okay, so what are SSRIs? What do they actually do? SSRIs are selective serotonin reuptake inhibitors, and they were introduced in the 1980s as the fix for depression. But here's the truth. SSRIs do not increase serotonin production. They do not fix serotonin deficiencies. They do not rebalance neurotransmitters, and they do not heal depression. A massive 2022 umbrella review published in Nature Molecular Psychiatry reviewed 17 major studies involving more than 150,000 people and concluded there is no consistent evidence that low serotonin causes depression. Let that sink in. What SSRIs do is they block the reuptake pump so serotonin stays in the synapse longer. That's it. They don't address inflammation, the gut microbiome, perimenopausal hormone shifts, trauma physiology, mitochondrial dysfunction, blood sugar instability, circadian dysregulation, or nutrient deficiencies. In many cases, they simply mute the symptoms without addressing the cause. And in some cases, they worsen symptoms over time. Now, I'm not saying that having more serotonin in the synapses between neurons
can't improve your mood. Just like taking ecstasy, MDMA, increases serotonin, you feel really good, but it doesn't mean that it's getting to the root cause. Okay, so I just want to list some of the common SSRIs that maybe you've been prescribed or a family member has been recommended to go on one of these. So fluoxetine, which is Prozac, it was one of the first SSRIs on the market. Sertraline, which is Zoloft, is very commonly prescribed for women with anxiety, depression, postpartum mood issues. Escitalopram or Lexapro is often marketed as very well tolerated and frequently is one of the first prescribed. This is what I was given in my 20s. Citalopram or Celexa is very commonly prescribed. Paroxetine or Paxil, known for its very difficult withdrawal, so be careful if you're on that one. Luvox is one that I'll often see women given for OCD. And then you have some related drugs that are not exactly SSRIs, but might be SNRIs or some that are commonly confused with SSRIs. So you have Effexor, which is actually an SNRI, also really hard withdrawal symptoms. You have Cymbalta, frequently prescribed for chronic pain. Wellbutrin, many of you've probably heard of Wellbutrin. That is actually not serotonergic. It affects dopamine and norepinephrine. So as we're talking today, I'm specifically talking about SSRIs mainly. So let's talk a little bit about serotonin specifically. So we often think about serotonin as this happiness chemical. That's not exactly accurate. It's a neuromodulator with over a dozen receptor subtypes, and each of those receptor subtypes does a different thing. So serotonin can influence mood. It absolutely plays a role in digestion, sleep cycles, pain signaling, platelet activation, your gut motility, sensory gating, inflammatory signaling, impulse control, and consciousness. And one of the most important pieces of information that I want you to take home today is that more than 90% of your serotonin is actually made in your gut, not the brain. And gut serotonin does not cross the blood-brain barrier. So it communicates through the vagus nerve, hence gut-brain axis, right? Immune cytokines, the enteric nervous system, which is the nervous system in your gut, microbiome metabolites, and inflammation-driven changes in specific pathways of the body. So this is why women with SIBO, IBS, leaky gut, candida, gut dysbiosis, or food sensitivities or allergies can often have symptoms like depression, anxiety, panic attacks, irritability, emotional reactivity, because the gut is telling the brain, we are not safe, alert, alert. And that message travels faster than any thought you can think. So SSRIs do not correct this communication. They simply intercept the signal downstream. So I want to touch on something called the kynurenine pathway. So this is a really important biochemical truth about mood. Tryptophan is an amino acid. It is a precursor to serotonin. So it can go down two paths. It can become serotonin, or it can go down the kynurenine pathway. Under chronic inflammation, so think stress, trauma, viral reactivation, even environmental exposure like mold exposure, perimenopausal hormone shifts, gut dysbiosis, poor sleep, insulin resistance, this pathway becomes overactivated. And this is going to lead to neurotoxic metabolites, oxidative stress, lower dopamine, so lower mood and motivation, lower GABA, which is your inhibitory neurotransmitter, so more anxiety, lower brain-derived neurotropic factor, so less neuroplasticity and essentially growth and change in the brain, mitochondrial dysfunction, and HPA axis dysregulation. Now, what does this clinically look and feel like? Depression, apathy, anhedonia, brain fog, irritability, profound fatigue, and emotional numbness. So inflammation, not serotonin, is often the root biochemical driver of depression. And SSRIs do not address inflammation. In the last few years, the research has become impossible to ignore. A 2023 paper in the Journal of Affective Disorders found something astonishing. Whether an SSRI works can be predicted by the composition of a woman's gut microbiome. Certain microbes, especially bifidobacterium species, are associated with a better SSRI response. And here's the flip side. Women with dysbiosis, SIBO, we just had an episode on that, right? Low short chain fatty acid status, high zonulin, or post-antibiotic microbiome disruption are significantly more likely to experience no improvement on an SSRI, partial response, worsening of symptoms, emotional blunting, or severe side effects. A 2022 study found that people with depression have a distinct microbiome signature, especially involving tryptophan metabolism and this pathway that I'm talking about. In other words, if the gut is inflamed or imbalanced, serotonin signaling is disrupted, and SSRIs may fail, backfire, or worsen symptoms in these patients. This is why so many women come into my office and they say, I didn't feel better. I felt different, but not better. Or I felt disconnected from my body or mind. I felt like myself, but essentially with some emotional blunting, or almost like you sandpapered the edges off of life a little bit. Some women will say that their mood did improve. So in the sense that they felt more emotionally stable, but they also didn't feel happy. And that's because it's not in your head, it's in your microbiome. And if we haven't worked on the microbiome, as I said, very often women can feel worse on SSRIs. Now, there's another reason you might feel worse on an SSRI, and that's clinically important to me. And that is that there's an enzyme called AADC, or aromatic L-amino acid decarboxylase. And it's an enzyme that converts L-dopa to dopamine, and it converts L-tryptophan to serotonin. And this is a limited resource. So when an SSRI increases serotonin availability in that synapse between neurons, more AADC is required to process that serotonin. But you only have so much of this available. So what happens? Well, serotonin steals AADC from dopamine production. So your dopamine drops, your motivation drops, your pleasure, your experience of pleasure drops. And essentially, your vital force is lacking or feels less than. Women will describe this as, I don't feel like myself anymore. I'm not sad, but I'm not anything. I feel flat. I stopped caring. I can function, but I can't feel. I've heard that before. And I'll often hear things like, well, I'm not as angry or irritable anymore, but I also don't have any joy. And this is pure neurochemistry. So this imbalance is one of the reasons why women can develop apathy syndrome, emotional blunting, sexual dysfunction, and worsen depression over time, even though they're on an SSRI. It also helps explain why some SSRIs help briefly and then stop working. Now we're going to move on to the withdrawal piece. And this is a piece that breaks my heart every time I see it in practice. This touches everyone. I have teenage males that have experienced this. I have adult men. I have women in perimenopause. I have young women. This is not just applying to perimenopausal or menopausal women, although I know that my audience is comprised of a lot of women, right? So if you're a man listening to this, this does apply to you as well. And withdrawal from SSRIs is very real, and it is, in my opinion, severely underreported. 2022 review showed withdrawal can last weeks, months, or longer. Withdrawal symptoms mimic relapse of original symptoms. Many women are misdiagnosed with returning depression when it's actually withdrawal physiology. Severe withdrawal is common, even when tapering. Some of the withdrawal symptoms that I see commonly, the most common would be these brain zaps, and patients will commonly describe this as this zapping feeling, dizziness, panic, intrusive thoughts that are not you. They're a neuroadaptive rebound from coming off of the SSRI. So I've seen patients suffer more coming off the SSRI than they ever did going on it. Again, these electrical sensations or zaps are very common. Inner agitation, rebound insomnia, so they can't fall asleep or they're not staying asleep, rebound anxiety, nausea, severe irritability, crying spells, dizziness, derealization, intrusive thoughts, return of OCD symptoms, akathisia, sensory overload, and worst of all, very commonly, these patients are blaming themselves. They believe that their depression has returned or that they've failed the medication. Like, why isn't this working for me? All my friends said they felt so much better on it. That I hear that all the time. But the truth is that their nervous system is recalibrating after receptor remodeling and serotonin transport changes. Your brain is trying to accommodate for what it just had occur. And now you've pulled that SSRI from the brain. And so it's trying to adapt to the new environment. And this is withdrawal. It's not relapse. And very often women were not told about this before they went on the SSRI. And that is the point of this episode. I am not saying there's not a time and a place. I am not saying that you cannot use a medication as a tool when necessary, but I am saying that you need to be told that it might be hard to come off, and you need to be told that there are other things that can be looked into. That is my main goal here. Now, another thing that many patients are not told, or patients of mine who are asking, should I consider using this for my son or daughter, my teen or young adult son or daughter? And I see a lot of teens in my practice as well. Again, I know this podcast is focused on perimenopause and menopausal age women, but if your teen or young adult child has been told to go on an SSRI, this is information they need to know. So we talked about how SSRIs are not increasing serotonin production itself, but they simply keep serotonin in the synapse longer. But this also has downstream biochemical consequences. So one is that it upregulates monoamine oxidase, or MAO. So you have faster breakdown of dopamine and norepinephrine. You have an increased demand for nutrient cofactors that can then become depleted. And you have depletion of precursor nutrients, so the nutrients you need to make these neurotransmitters. There will often also be gut irritation and absorption impairment. So serotonin moves things through the bowels, so you can have gut irritation, melatonin depletion, and mitochondrial stress. There are a number of nutrients that will become depleted on SSRIs. So let's give a real life example. Let's talk about Nancy. So Nancy started on fluoxetine. She felt slightly better at first. Months later, her symptoms worsened and her dose was increased. She felt worse on a higher dose, flat, numb, anxious, unable to sleep. And when she tried to taper, the symptoms were unbearable. So physiologically, what happened for her is that her serotonin receptors were down-regulated, dopamine had dropped, her melatonin was depleted, her MAO was upregulated, and she had depletion of B vitamin, zinc, and CoQ10, which are commonly depleted on SSRIs. Her gut absorption had also gone down, which further depleted these nutrients, and her nervous system had destabilized. She also, as a result, wasn't doing anything for her nervous system. So she wasn't acknowledging her autonomic state. She wasn't intervening in maladaptive stress patterns. She wasn't working on diet, and she wasn't moving because she was relying on the pill. And yes, research shows that fluoxetine, for example, depletes melatonin. TCAs that we mentioned before deplete CoQ10 and B vitamins. SSRIs impair nutrient absorption. And remember, 95% of serotonin receptors in the gut, well, you've got those GI side effects and neurochemical side effects of the SSRI. So that looks like, in Nancy's case, worsening depression, apathy, insomnia, brain fog, irritability, loss of joy. We talked a lot about finding joy again, chronic fatigue, and emotional blunting. So this is why nutritional psychiatry is a field. This is why you always address the terrain. This is why we start with the gut-brain axis. And it's why women must be told the truth that SSRIs change your nutrient needs. There are neurotransmitter dynamics that are impacted by these drugs, and that your microbiome changes as a result. So if you choose to use these as a tool, those changes have to be supported. Those deficiencies have to be addressed, or the medication will stop working, or it'll make things worse. And you're definitely going to have to keep increasing dose or switching medication. So that's probably been your experience. If you're listening still and you're like, oh, wow, that is my life, this is why. There's also another risk of SSRIs that almost no clinician I find discusses openly with patients. And again, I've been in practice for a very long time. I've had hundreds of patients come to me after being prescribed these. This is my clinical lived experience with patients. I'm I am in no way attacking the prescribing provider. Again, there's a time and a place. I assume that decision was made with the patient's best interest. Sometimes there's a different level of training based on who you're seeing. Of course, not every provider is going to know about root cause medicine. So please know that I really just want to provide information here if you are someone who's not been told this about SSRIs. So, this other risk that appears repeatedly in the research, especially in large population studies, in pharmacovigilance reports and registry data across Europe and the US, it's uncomfortable, it's complex, and it really deserves clarity, not just silence around it. And that's that some individuals, especially during the early weeks of treatment or during dosage changes, may experience agitation, restlessness, emotional volatility, impulsivity, irritability, akathisia. This is an internal state of agitation and motor restlessness, behavioral disinhibition, and in rare cases, aggression or extreme violent behavior. These are documented risks. This does not mean that SSRIs cause violence in a simplistic way, but the association is well documented in the BMJ registry studies, the Swedish National Cohort studies, FDA black box warnings, pharmacovigilance analyses. You can look at the work of David Healy, one of the world's leading SSRI risk researchers, and this risk is most pronounced in adolescents, young adults, individuals who experience that akathisia symptom, and individuals with rapid dose changes. Akathisia in particular is not anxiety or agitation. It's a physiological motor restlessness so intense that patients describe it as my body wanted to crawl out of itself. I couldn't stop pacing, I've heard before. I felt possessed. I felt like I had to explode out of my skin. I felt buzzy on the inside. And here's the most important part. Akathisia is one of the highest risk states for impulsive or aggressive behavior, including self-harm. So this is neurophysiology in distress, and most women are never told about it. Even though early SSRI treatment increases this risk of agitation, dose increases can trigger it, withdrawal can trigger it. And in my opinion, I think it is a very dangerous state to be in, especially if you weren't warned that it might be a side effect of medication. In my own clinic, I've seen women who were mislabeled as bipolar, told they were unstable, told they were decompensating, when in reality they were experiencing SSRI-induced akathisia or dopamine depletion as a result of the medication. So root cause care matters so much here because there is a root cause and there is a solution. This is why informed consent matters, not to scare you, to protect you. And certainly if you're experiencing these symptoms, a second medication to suppress the side effect of the first is, in my opinion, a disservice to women. So this is where informed, integrative, nervous system first medicine is essential. One day I will share an even deeper, more personal story than this on how I lost someone dear to me to suicide, but I really don't feel ready for that. So I'm going to tell my personal story with depression first. And because this is my own story, it's very raw and real. And I hope that someone hears it today and they are inspired to look for the light and to look for hope in their depression.
I hope you've been enjoying this 2-part episode on SSRIs so far. Tune in next week for part 2. And if this resonates with you or you feel like there's someone in your life who would benefit from hearing this message, please share it with them and download and subscribe so you don't miss any episodes of the Vital Spirit podcast. Thanks and have a great day.